everybody. This is Deborah Carey with Twice as Nice Uniforms. Get ready for your unofficial dental hygiene podcast.
These are the tales of two hygienists, one East Coast RDH and one West Coast hygienist. Listen as they tackle the profession of dental hygiene with humor and enthusiasm. Now, please join Michelle Strange and Andrew Johnston as they tell you a tale of two hygienists. What episode are we on?
92.
Good Lord. I mean, that's pretty much a staple of this podcast is us starting this, what episode are we on? When will we learn?
Probably never. So welcome to episode 92.
Never. Yeah, everyone.
Yay.
On my computer that I just got back from the Apple store last night so I could record this bright and early with you.
What happened to your computer?
The HDMI port just stopped working, and I need that to present, all the time. I dropped it off at the Apple store on Saturday because they told me, it'll be 3 to 5 days. And I was like, three to 5 what? Days without my computer? That's just not going to work. No. And they're like, okay, well, if you bring it in, drop it off Saturday night, it'll be the first on the bench on Sunday morning. So I dropped it off on Saturday night, and the guy was like, okay, 3 to 5 days. And I mean, obviously, I have a flair for the dramatic, if you will.
Yes, you do.
I almost passed out in the store. I was like, oh, no. I need it tomorrow. Tomorrow. I have to have this Monday morning. So thank you, Apple Store in Charleston, for getting my computer back to me.
So if you're ever in Charleston, listeners, go use the Apple Store.
Go to that.
It's a decent one.
Excellent.
Apparently.
It's a decent one.
So,
also, on another note of why I need a chaperone or supervisor at all times with me, and I don't really know how I travel as much as I do, and then make it back home. I currently, my car is the one that has the starter, the key just has to be in the car. You don't actually have to have it physically to crank it.
right.
My key is lost inside of my car. So anyone at any given time right now can just jump in my car and drive away because I can't lock it.
So if you guys were in Charleston, yet again, something else you can do is just go.
I really hope other people do
I
this.
wish I knew remembered your address.
Please make me feel better. Make me feel better. It's literally inside of the car. So last night for about 15 minutes, I searched my car because I got out and I was like, well, I can't lock it. Where is it? But I drove it. So the key's got to be inside. I just can't lock it.
And you're sure it was not on your person at all?
No, because if I was on the outside of the car with it, it would lock.
And I'm sorry that I'm dumb, but literally those 2 inches matter, between whatever side of the steel that you're on.
It knows if it's inside the car or outside the car. If I hit the lock button to go shut it, it just unlocks itself. It's a battle. It's lock, unlock, lock, unlock.
Very interesting.
The car's smarter than me.
Apparently.
To say the least.
Yeah. Well, I mean,
yes.
It is what it is,
So
buddy.
please, listeners, you are all so great to reach out and talk to us. Please tell me I'm not the only dum-dum that has done this. And the car.
Please tell her that she is the only
inside the car.
dum-dum. I want more responses saying, yes, you're an idiot, than I support you, Michelle, and your stupidity.
Well, that works too.
Yeah.
And I would totally understand that because, again, I should have a supervisor at all times.
Should.
So, what I'm excited about, one, is that we are going to the Iowa Dental Hygiene Association.
That's going to be really fun.
What?
It's in 2.5. It's October 6th or 7th.
Yes, October 6th.
The weekend.
Which is a Friday.
That weekend, whatever it is. Yeah, it's going to be really fun. Some of our friends
and
are
we're
going to be there, so they asked us to be there to lecture to students and talk to them about how to be engaged in the profession and, just that kind of stuff, dental hygiene stuff. And so...
Yeah, stuff we talk about all the time.
Things. And so, I think right now our course looks a lot like typical Andrew course.
So, I was going to give you credit for a moment that you did get me your outline for this presentation before the 24 hours that you did the last time you and I presented, which is why I freaked out and said I could never present with Andrew ever again.
But it was
I can't
bare
handle the
bones.
stress.
Like it was a skeleton outline. It was
it's something,
it was
Andrew.
the idea
I
of what an
appreciate
outline.
anything from you at this point. Now, if you come and hijack that presentation 24 hours before, I'm going to lose my mind again.
Be like, by the way, we're not going to talk about any of that stuff that we're doing. We're going to do a whole different direction. No, it'll be good. It'll be, I mean, it's very CE focused, as you and I are kind of CE junkies, and it's always about the pathway of learning, and just being educated about everything. And I think in our interview today, hold on, please hold. I have a quote. Let me find it. She said, okay, and Dr. I'm sorry, I'm going to butcher your last name, but I think it's Maragliano-Muniz. Okay. She said, we have a responsibility to our patients to continue learning and deliver the best at everything that we do. Amen. So, amen. Along those lines, that's what we're going to be lecturing on. I'm very excited about it. It's going to be fun. Yep. We're going to be in Iowa for a few hours and then fly back out. That's always fun. Yeah. So,
one thing that we always talk about, and it's something I hope that hygienists feel super empowered when they are done listening to our experts and people that come on this podcast. Because I was talking the other day, because we assume, or we make this kind of weird assumption that medical providers get more oral health knowledge than they actually do.
Right.
And our buddy Missy works with me at Tepe, does consulting with me, and Andrew loves Missy.
I do love Missy.
And Missy's a great human. She was saying like how a lot of her patients have angular cheilitis, and that she was saying like go to your dermatologist, go to your medical provider, and they can prescribe something. And then she had a nurse, somebody up kind of high in the nursing, or a professor or something, that didn't know what angular cheilitis was, had never even heard of it. And so I want us to feel super empowered that we are the experts in so much of this oral health side of things. And that when we call and we talk to these medical providers, like we need to do that with some level of authority. Now, not like it has to be this, like we have to do a scaling and root planing. I can't wait 6 months, blah, blah, blah. Because the medical provider is going to always know their end of it a little bit better. But explaining where that patient is in their own oral health so that we can all collaborate so well to help that patient.
Yeah. No,
so,
right.
For instance, like, I keep talking about like the whole pre-med thing. And, we just kind of yield to that receptionist when we call, and they're like, oh, nope, our protocol's 6 months. I'm like, well, that's not actually the standard. So is there a reason that this patient would need to take pre-med for life or for years or, whatever? And they're like, nope, that's just our protocol. Like, that's not where it should end. Like, that's a subpar standard of care, because now we're like opening up that patient for like issues because they're on too much antibiotics. Like, we should have a legit conversation with a medical provider, not just that front desk person, because we know their mouth and we know what they need, or, it's just, I hope everybody feels empowered after they listen.
Yeah. Well, I think that a lot of people do. And taking that empowerment and learning how to communicate to those providers and to your dentist, because it is kind of a tight line that you have to kind of walk.
It is.
You don't want to piss everyone off in the world. I mean, you do. You,
right.
Michelle, specifically do. The rest of us don't really care.
It's not my goal. It just seems to happen that way. Mostly on Facebook.
Yeah. So let's talk about let's talk about our interview. So, oh my gosh, this was probably, I always hate ranking them, but it's like one of my favorite ones because it's about CaMBRA. And so CaMBRA is obviously one of my passions. And for everyone that doesn't remember what CaMBRA stands for, it's Caries Management by Risk Assessment. So it's assessing the risk factors that make a patient higher risk or lower risk for getting caries. And so being a restorative hygienist, yes, I do get to place a lot of fillings, but it's also something that I want to be preventive based and say, we don't want to do these fillings. Let's remineralize and let's, change diet, pH and all that kind of stuff, and have that kind of a big picture discussion with our patients. And so she gave some really good points there. She's just an awesome person. She's really smart.
She is.
There was one time I'm not going to be able to repeat what she said but she was saying, I think it was a compound or it was some sort of scientific word, and it just rolled off her tongue like it was no big deal. We're like, wow, good job on that one. So.
No, she's great. She's a wonderful supporter of hygienists because she was a hygienist before she became a dentist, prosthodontist at that. So she's got some skills, and I mean, she does a little bit of everything, and we just love people who do that, who dabble and do it well in all areas that they are in. So we really appreciate her even taking the time, because she came early in the morning to meet us. And I'm pretty sure we weren't on our game because we were locked out of our room that day too.
I was on point.
I'm pretty sure you weren't, because you showed up after me.
Other than that, I'm very sure that I was on point. I mean, you know how well I do at early morning meetings.
Yeah, I know. So I'm not going to attempt to say her name properly. So Dr. Pam will introduce herself full-blown in the interview portion. So we hope you enjoy it.
Hey, Michelle.
Yeah?
It's time for the interview.
Oh, but I had something else to say.
We need to let the experts talk now.
Fine. Well, day 3.
Yes.
At RDH under one roof.
And you still have a voice, so I'm very happy about that.
I still have a voice?
Yeah.
Yours sounds a little grainy.
It's early.
It's early. It's not that early.
Interviews, it'll
it's not that early, but
you know what I really need is a rock star. Like that'll.
Oh, what a shock. Like, just look to your left.
Right here.
Look to your left. But awesome. It's okay, because our guest today is also drinking something that really makes you happy.
Oh, I know. I love that you're drinking Red Bull right now. Although Red Bull doesn't do it for me. Just throwing that out there.
Sugar-free Red Bull does it for me, and now I can't have you say my name because now I feel like a dental hygiene hypocrite.
We'll edit that out. Like, you are one of probably many. Many.
Well, I feel like people put up a facade sometimes, especially during interviews.
Oh, yeah.
Like, they don't want to be judged or whatever. I'm like, but at the office, like, we have cases of Red Bull in our
Oh, my gosh.
offices.
My assistant asked me for a Red Bull refrigerator. She wants that. Yes.
Yes. Because that's the new coffee.
I'm just waiting for your heart to explode one day.
Well, I'll also be a rich woman as soon as I die.
But the podcast wouldn't, and that's where I'm worried.
Do you know? I know you probably are super busy, but we've been doing this for a little while, and almost 2 years.
Almost.
Michelle has been interviewing co-hosts lately.
I'm looking for new co-hosts because Andrew pissed me off 2 weeks ago, and I was like, I will replace you, just so you know.
That's so funny.
Oh, anyway, so let's talk. I'm going to let you introduce yourself and tell us a little bit about. Is it super echoey in here?
Yes.
Okay. Just tell us about yourself, and like, you're here today lecturing, so we can talk about that too.
Sure. Hi, I'm Dr. Pam Maragliano-Muniz. I'm a former dental hygienist, which I always say I'm a hygienist for life, and I'm a prosthodontist. I own a practice. I'm a lecturer. I'm a writer, and I am a lover of Red Bull. I'm sorry, I am.
Self-proclaimed lover.
Don't apologize. Don't ever apologize.
I feel like I'm in a support group. I appreciate that.
Yeah. Well, I mean, one out of two of us over here.
I was going to say.
Support the crap out of you.
And I love wine. Wine's good too.
That's why you really work for this podcast. In the mornings you're with Andrew, and the afternoons you're with me. It's great.
Best of both worlds.
I love it.
Yeah, exactly.
I love that you were a hygienist first, by the way.
Thank you.
I've done that for a little bit, but I'm like, she's relatable.
So how long were you hygienist?
I graduated dental hygiene school in 1998, and then my sister actually was a hygienist first.
Really?
So she graduated in 1995.
Have that in common too.
Oh, really?
His brother is a hygienist who's here.
Oh, how cool!
But he acts like a sister sometimes, so it's almost the same.
Don't talk about Mike like that. I won't allow it.
You're so getting replaced.
Yeah, right? Yeah, so he's got a sibling. So she was a hygienist first.
My sister was a hygienist first, and now, as most hygienists know, and many dentists don't know, it's really hard to get into dental hygiene school. So luckily for me, Patty's little sister used to save lunch tables for the dental hygiene program, and I used to, when somebody had a cancellation, I was at the same school working on my science degree.
Aww.
So anytime somebody had a cancellation and needed somebody for Xrays or needed somebody for anything, they would drag me in. So I was their mascot, basically.
Right.
So when it was my turn to apply to dental hygiene school, I was sure it wasn't going to pan out. But luckily, Patty's little sister got in on the first try.
Wow, good for you.
Yeah,
Where'd you go?
I went to SUNY Orange County Community College in Middletown, New York. So I have an associate's degree from there. And then when I was getting close to graduation, I asked my sister, which looking back seems crazy. She was working. She loved her job. And I said, why don't you quit your job? We'll both move to Boston, and we'll get our degree at Forsythe to get our bachelor's. So she said, sure. And the two of us, she quit her job. We both applied to one school because that's where we were going. And thankfully, we both got in.
And you did your degree,
we have our bachelor's degree
at the same time.
Exactly.
Yes, I really like you and Mike. They were in hygiene school together, too.
Yeah, we were in hygiene school together, went into the same year, graduated the same. For us, it was, you had like lab partners and stuff, like Johnson and Johnston. We actually had a Johnson in between us, believe it or not. And so sometimes we didn't always get paired up, but we were always in the same groups and stuff. So
That's crazy.
Homework and everything was easier because we could study with each other for tests and whatever.
Yeah.
I was very lucky. My sister would make all of these amazing flashcards, and she would do that. And we'd be on the train going to a test, and I'm like, hey, give me those things. And so
good.
It was the perfect person to have with me.
It's nice, right?
Oh, yeah.
Oh, man. I don't say everyone should do it, but everyone should kind of do that.
With their sibling or something?
Or at least get a really best friend to go through it with.
Oh, absolutely.
The late nights, and, you don't want to be, as a young married man at the time, I don't want to be calling someone that's a single female 11 at night or 12 at night, like, hey, can I come over and study? And quote, study.
Or even
in all creepy,
absolutely. Yeah. And in dental hygiene school, I don't know if you guys did the same thing, but if you were having a rough day or if you needed some place to cry, the dark room was the place to do it. And so if you'd pull your best friend into the dark room and you could vent because you had all of that time for a fixer and everything else.
I know. And it's actually really loud in there, so it makes it muffles your sobs.
Absolutely. What happened in that dark room stayed there.
You come out and you're just like, I'm good now. I'm good.
Have you seen the doors, the rotating doors for dark rooms? That's what we had in our clinic before it got remodeled and stuff. And that was actually kind of cool because once you get in, it's a whole big room.
Oh yeah.
And sometimes you'd find people in there, and all of a sudden they stop talking when you walked in. Then they'd walk out having a rough day, huh?
Yeah. So how long did you practice?
I practiced full-time for 1 year. During that year, it was interesting because I really didn't have any dental experience. My only experience with working in a dental practice was I was an assistant for 3 hours.
Oh.
I was working for an oral surgeon. Now, before this, I wanted to be a veterinarian, and I had done a lot of really gross things in the pet hospital, but it never bothered me. I watched my first extraction, and the oral surgeon almost had to pick me up off the floor because I almost fainted. And so I'm there drinking somebody else's Diet Pepsi, and she's there. I'm fanning myself from the air conditioner, and she said, "I don't think this is going to work out." And I said, "Me neither." And I took off. So, and besides that, I worked in actually my sister's private practice for a short time as an assistant as well. And thankfully, I went about 6 months before I had to watch an extraction. So I really didn't have a lot of real dental experience, so I didn't know. So when I started working as a hygienist, I could spot a problem, but I had no idea how to fix it.
Yeah.
And so I found the end of the appointment to be so incredible to me because all of the dentists and prosthodontists I worked for were so clever. I could see something, and I would try to figure out what they're going to recommend, and it was never correct. And I just was blown away by what they were going to do. And I went from looking forward to seeing what their recommendation would be to thinking, I think I want to do this. So for me, it was really an evolution.
Yeah. And so then you applied for dental school?
I applied for dental school, and I was living in Boston at the time. And if I had a nickel for every time a patient said, "Oh, honey, you have to go to Tufts. You can't go anywhere else." So I felt like my fate was already decided for me because in the community, at least in Boston, at least in the offices I practiced in, they really felt strongly that I had to go to Tufts. So thankfully I got in, and Tufts was it. There was really no choice for me.
So you went to Tufts.
Yes.
And you did your residency there?
No, I didn't. I was at Tufts, and basically I worked as a hygienist the entire time. As soon as dentists know that there's a student that's a hygienist, pretty much every Saturday of yours is booked forever. And so I worked a lot, and I went to dental school, obviously. But then when it was time to go to residency, I decided to put the scalers down and really just want to focus on one thing.
Yeah.
And for me, it was to go out of state. And so I got into UCLA, which they only accepted 2 people in the program per year. So I knew I would get a lot of attention there. And I didn't have a dental hygiene license there. So I felt that I could really put all of my efforts into focusing on prosthodontics, because knowing me, as you can tell with what I do with the rest of my life, I would find time to work and I would find time to do other things. So I really wanted to spend my time focusing on prosthodontics.
Nice. That's nice. So what are the things you're doing now? Because you're practicing?
I practice. I practice in 2 practices. I own a practice in Salem, Massachusetts, and I work as an associate in Brookline, Massachusetts. And on top of that, I'm a lecturer. I'm the editorial director for DentistryIQ.com's Pearls for Your Practice. And so I write a lot. So it's a lot of things, but it's great.
You have time for all that.
I know.
Sounds so busy.
You just make it happen.
Yeah.
You know, it's one of those things that I'm interested, and I'm interested in products, and I'm
so then it
interested
doesn't
in
feel
new
like work.
things. No, and I feel also it's a responsibility to my patients to be up to date on all of the latest and greatest technologies, and if they come in with questions, I don't want to feel stumped by things. Obviously, I know where I can go to find answers, but I find that lecturing, writing, teaching, and working in practice, they all complement each other really nicely.
They do.
So
I would agree with that, yes.
I find that for me, each one is important to be the best at everything that I do.
Nice.
I like that a lot.
I know. So we're here at One Roof because you're lecturing with all your, Pearls for the Practice. And that you split that with Josh Austin, right?
I do. Hi, Josh.
So
I'm sure he listens.
I don't know. Sometimes I think he does. Sometimes
well,
we
he
listen
should.
to theirs.
I know.
We actually talked about. We had Kathy Bassett on yesterday, and Mike DeTola mentioned her in one of the last of their podcasts. Yeah, because she taught him some injections.
AMSA.
Yeah, and because he had never been taught that in dental school, and so she taught him how to do that, and she's a hygienist. So we were joking because you can't give anesthesia in Texas, and they were like, Mike was like, what kind of pretentious dentist doesn't think a hygienist can give anesthesia in Texas?
And Josh is like,
yeah. Like,
but there's a reason for it.
I'm sure there will.
That's what he says.
I don't know if that's the case, but so you obviously get to see all kinds of new products and fun stuff. Are there any that are super exciting for you right now?
Well, at RDH Under One Roof, there are a few new products launching, so it's really exciting to be here, and the energy here is extremely high. But I just brushed my teeth last night and this morning with MI Paste 1, so there's finally a brush on MI Paste, and I know that compliance is a big issue with some patients with MI Paste, and so now we can eliminate that extra step.
So, okay, break that down, because I haven't used MI Paste in my office. So why was compliance an issue to begin with?
So historically, and it's still going to be available, and I'm interested to see what my patients think, because I just placed an order for MI Paste 1 yesterday. But basically, to use MI Paste, you brush and floss your teeth or use whatever interdental cleaning device you're using. And then after you finish oral hygiene practices, you take a small pea-sized dollop of MI Paste, put it on a clean finger, and sweep it over your teeth.
Okay.
And so it doesn't seem like a big deal, and it's not a big deal, but you would think you're trying to recreate the wheel with some patients.
God forbid they do one extra step for their health.
Yes.
Oh my God. So now there's this is like a toothpaste-ish.
It's now a toothpaste.
Okay.
Yes, so it has 1,100 parts per million fluoride. It has recaldent, so amorphous calcium phosphate, casein phosphopeptide, which we all love.
God.
And
I'm sorry. You just like rolled off your tongue. Like, I've said that once or twice.
I know, it's like my middle name.
That's so good.
So it's got everything that that MI Paste Plus had, except it now has a light. It's got a light abrasive, so now it can be classified as a dentifrice.
Okay.
So it's now available to be used.
Maybe you could answer the question that we had yesterday about toothpaste and fluoride. So with MI Paste is distributed by the dentist.
Yes.
What makes it not able to be in the stores or over the counter?
Well, it's the same thing. It's like a prescription-based product. So
Okay.
it's in the same classification as a Floridex or ClinPro 5000 or, any type of...
But not because of the 1,100 parts per million fluoride, but the recaldent?
Probably the combination of recaldent. The other thing that is something to consider is that if a dentist is going to dispense a product in their office, you have control over the situation.
Oh, I totally agree with that.
I think that there's also a level of that. I don't think there's any product in there, and I could be completely wrong, but I don't think there's any product that is not acceptable for over-the-counter use.
However, it doesn't
However,
necessarily have to be prescription-based.
it doesn't have
but
to
it's
be.
office dispensed.
It's office dispensed.
Which is different, yeah.
Absolutely.
Okay.
So basically with that, then the office can see how often are you replacing it. Are you replacing it too soon because maybe you're
Going through it too
overusing?
fast? Yeah.
Or I have patients that bought a tube a year ago and they're like, oh, I've got so much left, I'm good. And you think, you sure do, because it's
you're probably
making
using it once a week.
Absolutely. So I think it's important for us to be able to monitor what our patients are doing.
I totally agree with that. I actually, one of my lectures that I'll do next week at ICOI is putting a little bit more value and emphasis on your goodie bag. And why are we dispensing products that we just like randomly get from, there's a discount on whatever toothbrush and whatever toothpaste. You're doing all these veneers, but did you give them the product that's right for those veneers, or did you give them the product that's going to be good for their rampant decay now? Like, why are we not helping our patients help themselves on that pharmacy aisle? Like, because it's overwhelming, it's intense. They go and they just grab whatever. Marketing is a bunch of bullshit with these toothpaste. Like, you put these like damn flex in there because we're not apparently smart enough to know that if it doesn't have flex in there, it's not like clean our teeth. It makes me so mad. So they get overwhelmed by marketing, and there's just not every product is right for every person.
I completely agree.
And I think it should be a little bit more like we should be helping them. Like I liken it to like prescriptions. If you have blood pressure problems, like your doctor doesn't say you have blood pressure issues, like go find yourself something, probably like a hydrochlorothiazide, just go pick one. Like no they're like, this is what you need because you're taking other medications, you have this, I'm worried about this, here is your prescription. I don't know why we don't do that in dentistry.
Well, I think it's also the nature of the practice and the nature of the dentist and the hygienist. It's the dental team as well, because I can tell you in my practice, everything that's in the goodie bag is purchased by me. It's not something that, I just got a free box of blank, so let me throw this at everybody. If there's something that, say, comes with a toothbrush or something, if it's not something that we feel is right for that patient, it either gets tossed or it's used for something else, and it's not necessarily something that goes into their goodie bag.
Right, because you don't even realize it, but you kind of put your professional endorsement on whatever you give them. Like, well, this is the one that she gives me, and I think it's going to be, should be a good toothbrush.
Should be good enough. I got it at the dental office.
Yeah, I got it at the dental office, and it's like the one thing that they hold in their hand for the next whatever many months that associates your practice with their product. Like, so I'm like, why are we professionally endorsing things without even thinking about, do we even know the RDA on some of these toothpaste and things like that? We don't do our investigation of it, but we just willy-nilly hand it out all the time.
I think it's true, and I think I agree with you completely, because I think a patient should be able to say, why are you recommending this toothbrush? And you should have an answer, and an answer that's legitimate, and not, because it was free. That's horrifying.
Right.
And I think that you should be able to cite the science or explain why the bristles are the way that they are and why this brush might be better than this brush for that specific patient.
Yep.
Clearly, I'm not the best practice management person on the planet, but I think providing individualized care is incredibly important.
I agree. Well, and that kind of goes into, so you're really big into CaMBRA.
I am.
And we've actually talked about this on another podcast that will eventually get launched one day when I have time. But explain, because I'm not restorative, and I don't really ever deal with, like, I could spot decay, but again, I'm sure there's somebody's going to go fix that. Let's talk perio. Like, I want to always talk perio. So CaMBRA was like, I knew it, I know of it, but I can't say I actually practice it. Maybe I do and don't even realize it. So what does that mean to hygienists to practice CaMBRA?
I think you probably are practicing CaMBRA without realizing it.
Yeah.
And I think that embracing CaMBRA is really identifying specific risk factors that are contributing to one's risk to develop tooth decay. And once you've identified those risk factors, assigning the patient to a risk category and then treating them accordingly, and then also documenting it properly. Mm-hmm. So I think...
Can I just interrupt you for 1 second?
Of course.
I feel like you said that so clearly and succinctly, and I really want our listeners to understand what you just said, because I feel like because this is what happens in the general practice. We get so bogged down, especially as hygienists, as we do the work, we do X, Y, and Z, and we don't look for those risk factors for caries. Necessarily, we say yes, they have caries, or yes, they have dry mouth, or yes, they have high sugar consumption, or whatever your criteria ends up being. But then assigning them to a risk level, I think, is really important, just like we would classify perio. Yeah. And I think that's one of the key things about CaMBRA, that, I'm sorry I stopped you, but I just don't want that to be glossed over. Like, there's another step, you guys. It's not just, yes, they have cavities. It's more than that.
And so you put them into a category, essentially.
I put them into a category: low, moderate, high, and extreme. And there are some CaMBRA gurus out there that have simplified it to low risk and at risk, or maybe low and high, or something like that to simplify it. Mm-hmm. But I still do like the delineations between low, moderate, high, and extreme. And I also believe it's not a punishment to be high or extreme. Mm-hmm. I think it's important to document it, because someday down the road, unfortunately, maybe restorations might fail, and if patients weren't informed that they were considered to be high risk for developing secondary caries or failure of their restorations, it's a liability.
You mean crowns decay?
Oh, no, actually, no, not crowns, because you don't need to brush those, right?
You mean crowns decay?
That's
what my patient's like, I have a crown on that tooth, I can't have a cavity. I'm like, oh, where did we miss this conversation? Yeah. I'm so I didn't play it. Well, perio office. I'm like, that was your general dental. Yeah. Okay.
No, but it's a big deal. It really is. And patients, obviously, and there's a disconnect, exactly what you're saying, that patients don't understand that if you have even a single crown in your mouth, then you have an extra job to do. Mm-hmm. It's not, obviously the tooth that you had broken down bad enough that you need a crown. Yeah. And now you have to take care of it. And I think that there are things that are missed there, without a doubt.
Absolutely. So you kind of take the risk and then you put them in these categories, and then what would your kind of next step be?
Our next step is to explain to them that we have identified this, and this as a risk factor, and for that reason we've placed them at, say, for example, a high-risk category for developing cavities, and we want to help protect them from developing new ones. Mm-hmm. So with that, we'll make risk management recommendations. Sometimes it's proper brushing and flossing or water picking or doing something to break up the biofilm. Sometimes we really would like to replenish the minerals that are in the saliva, and if that's the case, I do that with MI Paste Plus, and now I'll try it with MI1. Oh my gosh, MI Paste 1. I'm sorry about that. And I also recommend fluoride varnish to all patients as well. But it really comes down to bacteria, pH, and facilitating mineral exchange. So we try to identify the risk factors. I have my staff trained so they understand the role of those risk factors in the caries process. This risk factor contributes to bacteria. This risk factor contributes to pH. And this risk factor will contribute to a mineral problem. And so that helps us hone our recommendations. And it can be simplified, and it doesn't have to be that difficult. Mm-hmm. My hygienist gets 1 hour per patient, and this is done within the confines of a normal dental hygiene appointment.
Mm-hmm. So when you have these conversations with patients about their risk level, are there certain ways that you go about that, like motivational interviewing or anything like that? Because I'm sure if they're like high risk, like they almost feel ashamed. And how do you have that conversation where you're like, it's okay, this happens, but can I help you help yourself kind of conversation?
Again, I don't think it's a punishment, and I really try to be Cautious to make sure that they don't feel like I'm berating them or my hygienist is berating them in any way. Thankfully, my practice it's old. It's about 35 years old. So a lot of my patients have been there for a long time. They know my staff. They're getting to know me more and more. I've only been there for 3 years. And I think that they know that it's coming from a good place. So say, for example, they've got medication-induced xerostomia. And so we say, hey, you're on this medication. This might be the reason that you could develop a cavity because it could dry out your mouth, whether you realize it or not. Because if you ask somebody, hey, is your mouth dry? 9 times out of 10, they say no. Right. So it's a gradual process. They might not realize it's happening. So I just kind of skip over that. I don't ask them if they notice if their mouth is dry or not. But I can say, oh, I've noticed some changes. Your saliva looks a little different than it did last time. And so I want to keep you protected. I don't want you to have to get new restorations. Or you can even say, you've invested a lot of money in your mouth and we need to keep it healthy. And so it's not so much, you're at a high risk.
Yeah.
Go into that high risk category and sit in the corner. That's not how it is. So we really do it from a good place and from a caring place, and also from a really strong stance of prevention.
I think inherently people want to get better. I think there's always a competition within yourself for the most part.
If they have that internal locus of control, I think.
Right.
But those external ones, I'm like.
Well, and there's a way to use both of them, though. There's ways to do that, though, for depending on what the right. But we would do something very similar as we are explaining why they're in whatever category they're in. It's not a punishment. It's just a state of being. This is where you're at, and we're going to help you graduate to the next level, which is moderate, or we're going to graduate you to low. And once you do all these things, then you can stop doing all this other stuff because when you're in a higher risk, you're going to have more things, whether it's a remineralizing agent or whatever products helps stimulate saliva flow or whatever. And once they move out of that high-risk category, they no longer need to use those products. And that's a pretty good motivation, I think, for a lot of patients. And so they go, oh, okay, I understand this isn't a money-making scheme from the dentist or whatever. This isn't a whatever. You guys are really invested in helping us get healthier. And so do you have more questions on this line?
No, but I actually had this thought, I've never had this conversation, but I'm going to try it. Ask maybe the patient, if you were a dental patient, school, what grade would you want? Are you an A student? Are you a B student? Are you a C student? If I said you were a C student and you want to be an A student, could I tell you how to get there? Almost. Because if you were you're a C student, I would freak out and then probably be an anal retentive patient until they come back and see you again.
Well, I also think the intraoral camera plays a role in that too.
Oh, that's a good point.
Because anything, and I'm really, really, really excited about any type of product that is objective. Because I walk in and I say, I see this, this, and this, then patients basically have to trust me.
Yeah.
And, do they or don't they? I don't know.
You didn't put that crack in their mouth.
I didn't.
See it on the screen.
But if they see it on the screen, and then that's a totally different thing. Or inflammation or calculus buildup. They can see these things, and all of a sudden, their eyes are opened.
Right.
And I find that to be really, really powerful in the practice. So it's almost takes me and my opinion out of it. I say, this is what I see. Do you see this? This is what I want to see. And so we'll do a lot of befores and afters with restorations, with even prophylaxis, anything like that, so that patients can really understand that you're not just coming in for just a cleaning kind of thing.
We're making you help monitor your health at the same time, which I think is a great idea. So are you hygienists doing intraorals almost every visit, or is this kind of a sporadic as needed thing?
No, it's not sporadic as needed. The way that we do it is it's almost on a similar rotation as a perio charting or radiographs. Okay. So depending on what she has time for that day, she basically, hold on, I need to take a Red Bull break.
Nice. Tales of Hygienists brought to you by Red Bull.
Oh, God.
I love you, Red Bull. Anyway.
Yes.
I'm so outnumbered on this podcast.
It would be great for them to send you some products to sample, some new ones, new flavors.
As long as it's sugar-free. I'm not really, well, the thing is I'm into the sugar-free Red Bull because, it's a bad habit, but it's, I don't want it to be that bad.
It's less bad if it's sugar-free, obviously.
Standards with your bad habit.
I do have standards, so my
sugar-free too.
See? Cheers. So my
the best of the worst.
Yes, they need to flavor their sugar-free and see if it beats the sugar-free. So I don't know. It's a tough thing to beat.
Get on that Red Bull.
Yeah.
They listen to the podcast.
I'm sure they do.
They should.
Their highest executives do. Their lower level, maybe not. But
Okay.
just the important people do.
Glad you're in touch with reality. So going back,
intraoral cameras. So
Yes.
it's basically on the same rotation as, say, perio charting or Xrays. The way that we do it is if there's a teaching moment where we have to teach the patient from the standpoint of inflammation or redness or any type of lesion that we see in their mouth. Without a doubt, it's being taken that day. Anything that's deemed a quote-unquote watch area, we're taking a photo of it. So cracks, little shadows, anything that is quote-unquote, if it's getting circled in the dental chart, there's an X-ray, there's a photo, there's a perio chart associated with it.
Nice.
wow.
I like that, though, because it's... and I don't like it. A lot of dentists like it from the treatment standpoint. It's like, hey, this is where you are and this is where you are now. You see the big difference, and then it kind of help self-diagnose, like I need to get that fixed. But I like it because it also gives some credence to our profession. I like objective data as well for that singular reason, because I feel all too often that people think that, well, it's a money grab. And I kind of want to go down that avenue a little bit with you. Is practicing CaMBRA, the idea is that you're going to have healthier patients, and then the idea is you should see a reduction in work.
Yes and no. I find that technically, theoretically, that should be the problem, but that really hasn't been a problem. And I actually, when I lecture, I have slides to show the office that I won the Adult Preventive Practice of the Year in 2010, I followed the production of the practice. And believe it or not, the production in the hygiene department boomed like you wouldn't believe.
So it just goes to a different area.
But restorative didn't start to break down. What I was finding was that we also implement oral health related quality of life questions with our patients, and we ask them about comfort, function, aesthetics, and the perception of their health, because I don't think there's anything wrong with that, assessing one's value system. And I find that it still does happen, but not as frequently. I'm not chasing one cavity after another on a patient. And so once you get people healthy and they're starting to come in more routinely without that dread of the bad news, all of a sudden elective procedures pop up. I don't provide ortho in my office, but I'm finding there's patients who they don't like their crowding, and now they're talking to me about that, or we're talking about whitening, or we're talking about restorative. And no CaMBRA in the world is going to solve bruxism. So, I have plenty of patients that are cracking teeth, or, they have a healthy tooth that was restored with a large amalgam and it's breaking down. So I'm not seeing a slowdown in restorative from that.
That's a great point. That's a good question with a great answer, because that's what you... That's your one for the day. It's the one for the day.
Gives me one every day.
Just one. I like to build them up right before I break them down for the rest of the day.
That's how it should be. You have to keep them in line.
So I think that is like a really good point, because the fear I think you hear with hygienists will say they want to continue to do the disease repair model. Like, I'm trying to prevent, and they won't let me prevent because they're afraid that it'll take away from their margins or something like that, and it's just not the case. If you're doing it right.
Ethically, seriously, come on. I tell my patients, and I don't apologize for it, I say I am the most aggressive in this room, in the dental hygiene room, because if I can keep you healthy and prevent you, so my office is set up, hygiene's kind of more in the front of the office and restorative's in the back. So I say if I can prevent you from going into the back, into my office, into my room, then I'm doing my job, and what we're doing together is working. It's not my goal for you to come in at every hygiene visit and you have a new problem, because then there's something wrong with the practice. To be honest with you, if I never did another composite on an existing patient again, I wouldn't care, because I want my patients to be healthy.
Yeah.
I would much rather be making them night guards, making them, bleaching trays or whatever to keep my healthy patients healthy.
Yeah.
And to that point, when you were saying you want to reduce their risk, that's not a goal of mine, believe it or not. I treat dental caries much the way diabetes is treated. I mean, think about a diabetic. Overweight, don't exercise, maybe their diet isn't where it should be. They go on a medication, their blood levels even out. Are they still diabetic? Of course they are, yes, if they don't change those risk factors. Right. So why would we take the medication away because what's working is working? So I will keep them at that risk factor unless the risk factor, or I'm sorry, I would keep them at that risk category unless those risk factors are eliminated. So if there's somebody who's on medications or they have a removable partial denture, these things they're lifers. I'm going to keep them at whatever's going to work for as long as it's going to work. And to be honest, I'd much rather you spend whatever on a fluoride varnish than you come back and see me because your crown is now decayed and now I have to do another crown. It's never a good scenario. So I just keep them at that, and we just stay in that lane and go from there.
That makes sense. And I always go back to, again, my perio background. It's like, I always joke about once perio, always perio, because I don't know if that one patient that's now maintaining, mother-in-law came in town with, they have 5 kids and they're all like sick, and all of a sudden she fell off the wagon, and here we are again starting because that risk came back and home care went out the window and stress happened and bruxism and all these things. So I kind of keep them close because I know that they have a host response in a way that is super aggressive for their mouth.
Absolutely. And reassessing at every visit is important too, especially how quickly can a medical history change? How quickly can bacteria change? Right. So it's something that really has to be done on a continual basis. I'm not saying it's easy because it's not, but I will, and it does reside in the hands of the dental hygienist mostly, because in my experience, really the dental hygienist is the perfect one to be doing this. However, if you can make it through one hygiene cycle, what I find is when hygienists see patients come back and their root surfaces are hard, their tissue is better, they're healthier, you might even see on an X-ray a lesion that's either stabilized or even getting smaller. Hygienists are sold, but you do have to make it through that first, that first period of, the whole hygiene cycle to get them back.
So I'm at an outreach program, like just volunteering. So I need to see if I can throw this in the mix there. All the volunteer dentists will probably hate me because I'm always they're like, we just do PSR. I'm like, you will perio probe. This has to happen. PSR is not a standard. Are you assessing them for something? Tell me what's happening. But if I'm seeing this patient during scanner replaying, I think you need to be having some perio charting. But I don't know if maybe they practice it and I just don't even notice it. But
that's a good conversation to have with them.
Yeah.
Just get them out and
throw that out at the clinic. I'm sure they're going to be like, don't invite Michelle back ever. She can't volunteer.
Volunteer. It'll be fine.
Well, the other thing is you got to keep it simple. And so what I've done, and I think it simplifies things very well, is to...
You're good.
Okay. Is to have it all in a documentation template. So I use an electronic health record.
Put it in there.
It's all right there. The risk factors are there. High risk factors have an asterisk, so you don't even have to remember what's a bad risk factor versus a less bad risk factor. What's a sugar-free Red Bull versus a regular Red Bull. And then the risk categories are there. You click through those. The risk management recommendations are there. You click through those. And finally, what I think is almost the most important thing is documenting whether or not the patient was receptive to those recommendations, because you can make the perfect assessment, perfect classification, make all of the recommendations in the world, but sometimes the patients that are most in need say no, or maybe next time, or something like that, or they do think it's a money grab. Some people, you can't please them all.
No.
And so it's important to document that they were interested in doing this or not. Because if there was a problem, it's not like we didn't try.
Well, and then if they come back and like, well, no one told me I was going to have all these cavities. I'm like, actually, let me just look back in the charts. 14 times we've had this conversation already.
Yeah.
Absolutely.
Because they don't remember. It drives me crazy, though. Okay, but I want to talk about, like, if you have any thoughts coming from being a hygienist and now the dentist, is there a good way to help bridge that gap in communication between a hygienist between Andrew gave me a compliment, between the hygienist who is emotional, wants her patients to be healthy, but also says, I need, give me instruments, I need all these things, versus the dentist that's like, I'm at 70% overhead, I can't get you anything, but then all this animosity and contention, and they're battling all the time. Like, is there a good conversation that we could start to have to bridge that gap?
One of my most frustrating things is that there's this element of it's us versus them.
Yes.
And it really isn't that way. I mean, in my opinion, we should be a team. I will say on both sides is that I don't think dentists really understand the education that goes into becoming a dental hygienist. Mm-hmm. And I don't think dental hygienists fully understand the responsibility and the liability and all of the cost and everything else of running a practice. So I think that there's, an element of we all need to kind of stand in each other's shoes for
Absolutely.
a second. However, I think if you're a hygienist trying to do something in your practice, I think understanding the value system of that particular dentist is really the thing to, resonate with. CaMBRA can be profitable. So if you want to bring fluoride varnish, for example, into your practice, you can talk about the profit potential. And, and you can talk about all of these patients that you feel would be able to, or receptive to this, or patients that you could help with this. And let's talk about how this can help the practice from a business standpoint. And it doesn't take any more time in the practice. So it would really be kind of on the hygienist. Mm-hmm. If the dentist is one of those people like me that I just really want individualized care and I want my patients to feel welcome and I want them to really get the best services ever, then I want my hygienist to come to me and talk to me about how this is going to benefit my patients and how this is going to keep people healthy and how this is going to make our practice better. And every dentist has their thing. Yeah. But I think that open communication, and I think there are times when I can't buy all of the things I want to buy. Believe me, I want to buy things all the time, and I can't. Yeah. And I think that there's an element of, all right, we need to chill for a few months, versus when there's better months, you say, okay, maybe now's the time to talk about this.
I think being transparent in that side of it is really important.
Absolutely.
So that we can appreciate the struggle that you're having, or not struggle, but the situation.
Absolutely. Sometimes it's a struggle, I'm not going to lie. Yeah. But also I think making the hygienist part of the decision-making process. I can tell you when I wanted to introduce the intraoral camera into the practice, we went to our local dental meeting, Yankee Dental. I blocked a few hours aside, just me and my hygienist, and she and I were shopping. Mm-hmm. And I said, my only thing is it has to integrate fully with our electronic health record. I don't want to be doing all kinds of extra things.
Bridging between software programs.
It needs to integrate perfectly. And I basically sat there as the patient while she took every camera and stuck it in my mouth and saw what was comfortable in her hands. Yeah. And so then once we figured out the few that integrated with our software, what was comfortable in her hands, then I looked at cost and saw, where we could, which one was the best one for our practice. But she made that decision. I sort of okayed it at the end. And she uses it all the time. And it's one of those things that so many dentists say, oh, that camera collects dust. It's not. But if I say, oh, here's a camera, you need to use it now, that's different from we need to document better, because when I can't remember every crack on every tooth that I've seen for the past 6 months, it's not possible. And I want to be able to tell patients if they're getting better or worse. Right. This is something hygienists love. I mean, this is what we do, right? Yeah. Yeah. And so that's only going to make our job better and us better educators to our patients. So to make her part of the decision-making process, for me, it was a slam dunk.
I think that's great. I think that understanding the value system, I think both ways too, because like Andrew's super business oriented as a hygienist, but I'm like irrationally emotional about things. So like approaching me, if you say like, this is going to make us more money. It's going to make us more profitable and blah, blah. I'm like, I heard nothing about patient health. I heard nothing that my patients are going to be happy and healthier and they're going to be like happier or like better in my chair, and I'm going to work less, work smarter, not harder.
Right.
And I'm going to get totally shut down. But, if you throw numbers at Andrew, he's like, yeah, that makes sense. I can deal with that.
And our patients get healthy also, but yeah, the number makes sense.
The number makes sense.
It's a balance.
Yeah.
It really is a balance. I mean, I can't do, I don't own a spa, so
right.
It's one of those
right.
things that you do have to, provide health, provide individualized care, make it a great environment for the patient and hopefully a good experience, but it truly is a balance.
Absolutely. I
agree. I think that if you can kind of figure out what the balance is in your own, in your own particular practice, I think then hopefully it's just a better place for the dentist and the hygienist. There's nothing worse than a stressful office.
God, right?
It's just terrible.
I hate getting up in the morning and going to work. I was in the very end of my hygiene, full-time career, and I was like, I'm not going to let them get to me today. I'm not going to let them get to me. And we go into that huddle, and one thing would come out, I'm like, I hate all of you. I hate everything about this office. Everything. And I don't like that.
And then you end up in the lunchroom with that one person that you have an issue with, right? Like, how do you end up with just that person?
Right.
And then you're there, like, do you talk? Do you stare at your phone? Do you just, I don't know.
It's like the universe, throwing it.
It is just an energy suck like no other. It is terrible.
It really is. Okay, so one final thing to finish us up. And this is going to be really great because you're a hygienist that's done this before. For new grads, students, do you have any words of wisdom, things to remember when you're either in school or when you get out? Don't forget, or don't worry, you'll get knocked on your ass, you'll get back up.
Well, you'll definitely get knocked on your ass and you'll get back up. I'll never forget that I failed because my bangs were too long once. So I mean, we've all had our struggles. Yes. I can tell you that I've had many, I mean, we could have a whole podcast about all the bad things that happened to me.
We will.
We could.
Mental note.
We could.
Mental note for future.
Let's do that in the evening with wine. It'll just get crazier. No problem there. But no, I think that you will be challenged and you're going to be emotionally challenged. You're going to be physically challenged. You're going to be academically challenged. But then again, it's all finite. You're going to get through your education, and believe it or not, you're going to look back upon it fondly.
Yeah.
The faculty that were the hardest on you,
you'll learn the most
you're going to learn the most from, you're going to have the most respect for, and just take a deep breath, and every once in a while, look around you, because you're around some really great people, some inspiring people. Faculty, they've devoted their career to really teaching you, and you're going to have a great career, and you can make whatever you want of it. You can be in practice. You could be doing podcasts. I mean, there's so many opportunities for you. So just take a second, enjoy it, and realize what it is that is exciting for you, and then go with it.
Good stuff.
That was good stuff.
Yeah. Well, thanks for getting up, because I know you're here just for today, literally. You're going to lecture after this, so thank you for carving out some time, because I know that's not easy when you're about to go lecture. So
that's okay. Thank you for having me.
Absolutely.
This was great.
Contact info.
Yes.
If anybody wants to get in touch with you, have questions, talk about CaMBRA, how could they do that?
Oh, I'm so accessible. It's almost ridiculous. The only thing I'm not on is Tinder. But I mean, you can Instagram me at Salem Dental Arts. You can Facebook me, Pamela Maragliano Muniz. Good luck spelling that one.
I don't even attempt to say your last name.
Don't worry.
I know. It's
just click on the link. It'll be fine.
It'll be there somewhere. Or you can Facebook my office, Salem Dental Arts. You can email me. So that there's that, and so I can give you my email address, and we can make that available. Or come to a dental hygiene conference and come find me.
Heck yeah.
Absolutely.
Yeah.
I'll be the one in black with a Red Bull in my hands.
I love it.
Well, thank you so much. We do appreciate this.
This was fun. Thank you so much.
Listeners, I want to tell you a story I found on the web, which makes this Scaling the Web with Andrew. All right, so this week when Scaling the Web with Andrew, in keeping consistent with what we had mentioned several times in last week's episode with Mary Otto, and also with this week's episode in discussing CaMBRA, I wanted to kind of delve into the Forsythe Experiment that was mentioned multiple times. I feel like a lot of people aren't going to be very familiar with it. I put a link in the show notes for last week's episode, and I'll put a link in this week's episode as well. Let me give you guys a little bit of background, but just so you know, this is published in the Journal of Dental Hygiene, which is a publication of the American Dental Hygienists Association. And the experiment was in training hygienists that were already licensed to be able to perform restorative procedures. And this was a study that was performed by dentists. And so let me read you a few things, but I would really encourage you guys to delve into this. It's a little bit longer than we have time for today, but I'll read the abstract. Okay. So it's entitled The Forsythe Experiment in Training of Advanced Skills Hygienists. A curriculum for teaching restorative procedures to dental hygienists has been developed. It was found that with the dental hygienist's knowledge of basic science, only 12 weeks of additional didactic and preclinical training was needed for her to master cavity preparation and placement of filling materials, which are in a plastic state at the time of insertion. During the 13 weeks of internship which followed completion of the preclinical training, the advanced skills hygienist performed high-quality restorative work and achieved a reasonable level of productivity. After an additional 12 weeks of practice, the mean productivity was 5 surfaces per operative hour and approached the productivity of experienced staff dentists, 6 surfaces per working hour. The study demonstrated conclusively that the advanced skills hygienist is capable of providing high-quality restorative dentistry while working under the direct and immediate supervision of the dentist. The cost of the additional training was calculated at $2,300. Projections were also made of productivity and income potential. It was concluded utilization of this type of auxiliaries may provide high-quality dental care to more people while containing, if not in fact decreasing, the cost of restorative services. For the introduction, the rationale of the educational experiment reported in this paper is that a significant increase in the individual dentist's capacity to provide quality treatment for more people at the lowest possible cost may be achieved by greater utilization of trained auxiliaries. So basically the idea of this whole article is not taking power away from the dentist, not taking away work from dentists, but having what they mentioned, increasing the individual dentist's capacity to provide quality treatment for more people at the lowest possible cost. So they did this study. There are a lot of subheadings for this. They talked about the selection of the trainees. They picked hygienists from 3 different schools. They were all graduated in the same year. And this is back in the 70s. So it's been several years since this has occurred. But each of the students had only been a graduate, I think, of less than a year, because I believe it was 1971 is when they completed their 2-year hygiene program. I think 1972 was when the instruction started for the advanced skills. They discussed the curriculum and the staff that was included in teaching these hygienists. And they created also a rubric or an evaluation of the restorative procedures. So objectively looking at how the restorative procedures were completed. In this study, it's also important to remember that they were preparing the tooth, not just filling the tooth. And so it's a little bit different. They talked about the time required and quality of specific procedures. A really cool thing about the time requirement, the mean time required for completion very first class 1 occlusal cavity preparation on the mannequin was 34 minutes, while the 4th preparation only took 19 minutes. As would be expected, the more difficult multiple surface preparations, class 2 and MOD, required more time. However, on successive attempt, the mean time decreased. It's interesting because you think also about, scaling and root planing procedures and all other procedures that we learned about in school. We think about how long it took us to complete the, half a mouth or a quarter of a mouth. And, in school you have 3-hour blocks or 4-hour blocks. When they mentioned about productivity, they said it should be noted that 13 weeks of productivity of the trainings was between 3 and 3.5 surfaces of completed restorative dentistry per operative hour. During the succeeding weeks of clinical practice, the productivity steadily increased so that by the time 25 weeks had elapsed, the group could consistently produce 5 surfaces of completed restorations for every hour spent with patients. The staff dentists on this project, who delivered restorative services for patients in the same environment and under identical working conditions, consistently produced a mean of 6 surfaces per operative hour. So only 1 more surface per operative hour than the skilled hygienists. Each team composed of a trainee and a dental assistant spent 65% of each 6-hour working day in patient contact. They talked about patient acceptance and educational costs, income producing potential, and about the educational costs. I think they mentioned in the abstract, it was $2,300 for the advanced skills hygienist education. I think it's going to be quite a bit higher now since it's not the 70s any longer. They talked about income producing potential, and I want to finalize this with reading the concluding remarks. The questions most often asked concerning the Forsythe program are the following: why use hygienists when they are already in short supply? Why use the hygienist in restorative dentistry when, by tradition, hygienists belong in periodontics and prevention? The reasons are that hygienists are already licensed and can be regulated by existing dental boards, and the hygiene curriculum is extensive in those basic sciences which dental educators consider prerequisites to clinical dentistry. In addition, as now utilized in most private practices and as limited by some state laws, statutes, regulations, most hygienists are overeducated and overtrained or underutilized. Another strong argument in favor of the idea of expanding the hygienist duties is that the potential breakthrough in the control of dental diseases may lead to a drastic decrease in the demand for restorative services. It certainly makes good sense to expand a pool of auxiliaries requiring far less education than dentists, rather than to run the risk of overproducing professionals who must invest 7 to 8 years in preparation for a career. The current surplus of PhDs, engineers, and teachers is a harsh reminder of this possibility. A look at educational facilities reveals that there are 150 schools of dental hygiene. These schools have well-equipped clinics which, in the advent of a care crisis, easily could be adapted to teaching advanced skills, including restorative procedures. In addition, if the new facilities should be required to teach expanded intraoral functions, it costs less than $1 million to build a hygiene school, while the current cost for dental school ranges between $15 and $35 million. Furthermore, as pressures create demands for more dental care, it is probable that the focus will be on children for whom dental decay is the greatest problem. The Forsythe program has concentrated on restorative dentistry because restorative services make up the bulk of the public's demand for dental care. This is the area where expanded duty auxiliaries will have the greatest impact on dentistry. So that's just a little recap on the Forsythe Experiment in training of advanced skills hygienists. And it's important to note that for many years, there are states that have been utilizing these quote-unquote advanced skills hygienists. And it's been, I think, a blessing to many of the dentists that know how to use them properly. I think it has increased productivity. I think there's been an acceptance with the public. And I think that the quality is high. And it is something I think that as hygienists, since we are so picky and so hard on ourselves, I think that we will continue to grow. And I think that we are a good representative group to be able to perform these functions. In the past, I've always talked about, dental assistants and what they should be doing, what they shouldn't be doing, et cetera. And this is one area where I feel that because of our education level, I think we are much more qualified to be placing fillings than the dental assistants. But it all goes back to education. It's whoever has the education and the experience and the exposure to situations, I think those people will be the ones that are successful.
It's about that time. Grab your blanket and a glass of wine. It's story time with Michelle.
So Story Time with Michelle is in honor of our wonderful interview that we just had, talking about CaMBRA caries risk assessment. But also, we've been talking a lot lately about silver diamine fluoride. And so I have an abstract, or actually a whole research article from 2017 from the Journal of Prosthetic Dentistry. And the title is Use of Silver Diamine Fluoride for the Maintenance of Dental Prosthesis in a High Caries Risk Patient, a Medical Management Approach. And so I'm going to read this. And again, it's from a 2017 journal, and I'm looking to see if there is a volume at issue. It does not have that on here. So you can just probably go to Google Scholar or scholar.google.com and at least get the abstract, but I'll read to you this article now. So because of the rising number of aging, partially dentate patients, the need to manage caries risk in patients with prosthesis has increased. Prosthetic retainer teeth are associated with a high risk of caries. In patients compromised by medical, physical, or cognitive disabilities or xerostomia, preventing the loss of prosthetic retainer teeth because of caries presents challenges for the maintenance of existing prosthesis. The cohort experiences numerous challenges that increase caries risk and compromise dental health. Age-related gingival recession exposes more root surfaces that are more susceptible to caries. Medication-induced xerostomia, autoimmune diseases such as scleroderma and Sjögren's syndrome, dementia, and frailty place patients at a high risk of caries in the retainer teeth. Patients with substance abuse problems, including meth addiction, face similar problems. The elderly, medical compromised, and substance abusing patients experiencing dental caries may face a number of barriers to the conventional restorative treatment. Difficulties with finances, lack of mobility, lack of access to care because of the lack of transportation, frailty, and inability to undergo treatment as a result of cognitive or medical conditions. These issues point to a need for a way to treat numerous teeth simultaneously and to limit expense, number of visits, and the time spent in treatment. The prevention and treatment of recurrent caries in the retainer teeth when prosthetic replacement is not feasible can be challenging. Technical difficulties such as access to frications or the interproximal surfaces of fixed dental prosthesis may occur. The excavation of caries may lead to endodontic complications or to weakening of the retainer teeth, increasing the risk of failure by fracture. Traditional restorative dentistry may be unavailable, may not be suitable for certain patient populations, and may fail to stop disease progression. The medical management of caries is an adjunct to traditional restorative options. Chemotherapeutic management of root surface caries helps reduce the need for invasive restorative approaches and offers dentists the advantages of speed, cost-effectiveness, minimal armamentarium, and portability when treating patients who lack access to care. The management of dental caries has included oral hygiene instructions, prophylaxis, fluoride rinses and varnishes, chlorhexidine varnishes and rinses, glass ionomer cement applications, and salivary stimulating xylitol gums or mints. Silver diamine fluoride, also known as SDF, is a treatment method for these patients and is newly available in the U.S. It is more effective than fluoride varnish and equivalent to or better than glass ionomer. Numerous well-designed clinical studies have confirmed the effectiveness of SDF. Of particular interest in the management of dental prosthesis are studies demonstrating that an annual application of SDF in groups of community-dwelling elders prevented and arrested root caries. SDF promises to be valuable therapeutic measure as part of a comprehensive prevention plan by dentists and dental auxiliaries, as permitted by local statute, in the treatment and prevention of root caries. SDF was approved in 2014 by the U.S. Food and Drug Administration and entered the U.S. market in 2015 to treat tooth sensitivity. It is now being used off-label to treat and prevent caries using current dental terminology code D1354. In the U.S., SDF 38%, I'm not going to get this chemistry correct. Anyway, is marketed as Advantage Arrest by Elevate Oral Care. One drop is sufficient to treat numerous sites at a cost of 50 cents, much less expensive than other minimally invasive treatments such as glass ionomer or the atraumatic restorative technique. SDF treats caries by forming a layer of silver protein conjugated on a caries surface, increasing resistance to the acid dissolution and enzymatic digestion. It acts directly against bacteria, outperforming other anti-caries medicaments and killing cariogenic bacteria in dental tubules, penetrating 50 to 200 micrometers into the dentin. SDF helps prevent new caries from forming. When the treated surface is challenged by reacidification, the silver is available for antimicrobial action upon release, and treated areas protect the whole mouth by causing the zombie effect, where silver-killed bacteria kill living bacteria upon contact. However, additional clinical studies are needed to demonstrate the longevity of these effects. SDF has been used safely for over 100 years in the U.S., Japan, and other countries with no reports of adverse reactions. When SDF contacts soft tissue, a small, mildly painful white lesion can occur, which resolves in about 48 hours without additional treatment. Contraindications include desquamative gingivitis or mucositis, and silver allergy is an absolute contradiction. The indications and technique for SDF treatment are illustrated by a patient from an author's private practice. A 53-year-old woman presents with recurrent caries on her mandibular right first and second premolars, which served as fixed partial denture retainer teeth. Her medical history was significant for scleroderma, resulting in severe xerostomia. SDF had been applied once, but caries remain. She expressed concern regarding dry mouth symptoms and confirmed compliance with caries management risk by assessment, or CaMBRA, protocol of twice daily brushing with 5,000 parts per million fluoride toothpaste and a chlorhexidine 0.12% mouthwash with the first week of each month. Use of xylitol mints was sporadic. Light to moderate plaque was present on the gingival 1/3 of the tooth surface. A limited mouth opening of 22 millimeters precluded fixed dental prosthetic replacement. The decision was made to continue using SDF to control caries in the retainer teeth. The patient was recalled in 6 months for evaluation using the back of number 2 Explorer. The root surface of the mandibular right first and second premolars were determined to be firm and non-carious. Caution was taken to not to use the sharp end of the Explorer on the treated surface to prevent disturbing the treated surface and introducing bacteria into the vulnerable subsurface. The glass ionomer restorations were intact. For aesthetic reasons, the maxillary anterior teeth had been treated with 5% sodium fluoride varnish at the same time as SDF was applied. These teeth developed open, shallow, diffuse root caries. So the technique that they used was 1, discuss risks, benefits, and alternatives with the patient or authorized caregiver, including the expected dark staining of caries infected root surfaces. Inform the patient about brief metallic taste, obtain written informed consent, and cover relevant operatory surfaces with plastic wrap to prevent permanent staining of countertops by the SDF solution. Number 2, assemble armamentarium, the 38% SDF solution by Advantage Arrest, a micro brush, and a plastic dappen dish and cotton rolls. 3, dispense 1 drop of solution. Recommended limit is 1 drop per 10 kilograms per treatment visit at weekly intervals. This dose is commensurate with Environmental Protection Agency allowable short-term exposure of the silver. 4, you want to apply lubricant to the lips to prevent temporary discoloration of the tissue. 5, you want to establish cotton roll isolation to minimize metallic taste. 6, you want to air dry lesions to be treated. Suction to avoid inadvertent swallowing of the solution. 7, you want to apply the SDF to the affected root surfaces with a microbrush for 1 minute. Then 8, you want to apply the glass ionomer to cavitated surfaces to restore cleansable contours if indicated. 9, you want to instruct the patient to rinse thoroughly and expectorate. And 10, advise patient that there is no waiting period for eating or drinking. 11, repeat the treatment twice yearly to maintain caries risk. The technique presented is the application of SDF to arrested root surface. Root caries, Significant data are available on the effectiveness of SDF in the prevention and treatment of dental caries in children, elders, and people with a variety of medical conditions. Although not a substitute for traditional restorations, SDF is a useful agent in the medical management of disease in those patients unable to tolerate, afford, or gain access to traditional restorative dentistry. So this is a really good article. I like that it gave technique. It's got some really good pictures as well. It does show the blackening of the root surfaces. So that is, a side effect that is unfortunate. However, decay turns black also. So here's, whatever. So we want to thank you again for listening to another episode of A Tale of Two Hygienists. Thank you for all of your support, always sending in your questions and your feedback, either via Facebook Messenger or on our wall. You can always email us at ataleoftwohygienists@gmail.com. Also, thank you for liking or doing reviews on iTunes. That is always very helpful. And please don't forget to share the episodes with any of your Facebook friends or in your Facebook groups. More the people start to learn about all the wonderful people and guests that we're having on this, the more information we can get out to those hygienists that can then help patients. So thank you again. We appreciate you, and we'll see you next week.